So good afternoon, and thanks for your hospitality for having us here today. What I'd like to do is give you a flavor of the state of affairs in that new area of immuno-oncology, which is really only a success story since 2011. So it's basically 3 years. It has a history that dates much further back. So we've tried to use the immune system to treat cancer for more than 100 years. Most of that was unsuccessful. And the real tipping point of changing our outlook on using the immune system for cancer treatment really is 3 years old. So let me achieve the following today with this presentation. Those are my objectives. First, tell you a bit about the history and what caused the tipping point. So why did we look at this so differently today than we have done in the past? And then go from there to the state of the field. Where are we actually today? What are the opportunities that have resulted from that tipping over of the viewpoint on this new technology? And then the last piece is what I call the next frontier. So basically, what's the outlook? What do we still have to solve to maximize the value in this area? So having said that, I'll start with the tipping point itself. There's an interesting history here. If you look at this graph, it's a gross oversimplification of the history of this field. It's more than 100 years, and it basically starts with a very crude observation of what's called Coley's toxins. So William Coley was a surgeon at Memorial Sloan Kettering in New York. He used to treat patients with very bulky tumors. If he could resect them, it was, of course, the preferred option, but in many cases, surgery was not possible. So in those cases, he actually created a bacterial cocktail and injected it into the tumor, causing massive inflammation. And that inflammation, in some cases, led the tumor to melt away. In other cases, it caused sepsis and was not a good thing for the patient. But the bottom line is, you can actually use the immune system, even with crude methods, to treat cancer. Unfortunately, at the time, the immune system wasn't understood. People didn't really know what they were looking at. So it was empirical, and it took a long time to evolve the science until we could actually start thinking about making drugs to target the immune system. So if you look at this time axis, there's a long period of time where everything stayed flat. We didn't really make progress. In the 70s, this changed with our ability to make monoclonal antibodies that you could then use to target specific immune pathways. But even there it was early because we didn't understand the pathways very well. So from that point on, there are a few milestones on this chart. You see the curve going up, but the real breakthrough only came in the last decade. And it led us to drug approvals in the areas of cellular therapy, which is Sipuleucel T, that's the Dendreon vaccine, you probably are familiar with that. And then the two checkpoint modulators, CTLA-4 first, which was ipilimumab that Paul referred us to, and then PD-1, which is probably the hottest thing in oncology right now. There's several PD-1 programs by several major pharma companies in late-stage development. Now, from this, let's actually take a look at what has caused us to see success in this area so late in the game. There are two areas that contributed to that success. The first one is the scientific evolution. Scientific evolution in the sense we understand the immune system better, we understand the pathways of the immune system, and the two major components of inducing immune responses and controlling those immune responses through immune suppression. And the balance between the two, you need to be able to influence if you really want to have a successful manipulation of the immune system to treat a disease, in our case, cancer. Now, in parallel to the scientific evolution, there has been a methodological evolution. And I wouldn't underestimate this simply because if you understand what pathways to target, but you don't know how to measure that adequately, particularly in clinical trials, you may still miss the effects you're looking for and therefore don't have a successful program. So one thing we learned is we learned how to step away from the chemotherapy path of drug development towards a new immunotherapy path of drug development. In oncology, as you know, historically, everything has been poison development, if you want, chemotherapy. And the chemotherapy is a very specific way of targeting cells. It's a poison, it goes directly to the cell and either has an effect or it doesn't. Immunotherapy operates very differently, and I will walk you through a few observations that have contributed to us understanding this better and then leading to development success and increase of value in this area. So let's do that. Clinical endpoints and response criteria are the focus for what I'm going to show you next. The list here is too long to go through all of that today. But those two are the most impressive, and they're probably the value drivers for immuno-oncology clinical development. Now, here's a simple statement about cancer immunotherapy. When you make an immunotherapy drug, you're not treating the cancer. You're treating the immune system. The immune system then, in turn, builds a response that targets the cancer. And there is a time delay between those two events. So while you introduce the drug to the patient, it may take weeks to months before that adaptive immune response has been built to have a true effect in the clinic. And that time delay, you have to understand it, you need to know what to look for, and you need to know how to measure that to not miss the effect overall. I'll show you examples for that make this very apparent. Now, here is a brief summary of how the immune system and the tumor interact with each other. So basically, start in the right upper corner, you have normal tissue. These are normal looking cells. They acquire mutations, they become tumor cells. Those tumor cells already have unique aspects, mostly driven by those mutations, that actually are recognizable by the immune system. You do get immune responses against the tumor. It's just not enough to really clear the disease. So we want to manipulate that to strengthen the immune response and really get effects on the tumor. And what can happen then is that you either get a state of elimination where the tumor gets melted away by the immune system because the immune response is strong enough to achieve that. A second scenario is that you have an equilibrium. There is an effect of the immune system on the tumor, but it's not strong enough to clear the disease. It just creates a balance. But a patient that lives longer because of that balance still has a form of clinical benefit. And then the third piece is where the tumor wins the battle. So the tumor outgrows the immune intervention, and we call that escape. So if you want to translate this into response observations in clinical trials, you can make create three very simple terms. The first one is response. And you often hear this, complete or partial responses in clinical trials. That is the state of elimination. If you go to stabilizing disease, usually not recognized as benefit in clinical trials, particularly by regulatory authorities, that is the state of equilibrium. And then the third one is obviously progression of disease, where the patient apparently doesn't benefit because the tumor outgrows the immune system. Now, I'll show you that this is not as clear-cut as this schematic suggests it when you actually look at clinical patterns of response. So here are 4 patterns of response that we have observed in the first checkpoint modulator program, which was ipilimumab, or CTLA-4. The first pattern on the left upper corner, pattern A, is a conventional pattern as you see it with chemotherapy, targeted therapies, and also with some immunotherapies. The way to read these graphs is you have a time axis down here, and you have a tumor volume axis up here. When you start measuring, you start at point 0. That means that's the tumor volume at baseline. That's what the patient starts with. It's a certain amount of tumor that you then impact on either through shrinking it, the curve goes down, or the tumor grows, the curve goes up. So in this particular example, you have a tumor reduction of 100%, a complete response, and it happens immediately. You start treating here, the curve drops, and you're at a minus 100. So this is a classic chemotherapy response if you have it. Now the 3 other patterns are more immunotherapy-specific patterns. The first one is more universal. Now let's look at what they look like. This thing here is basically stable disease over a prolonged period of time. So you start again at point 0, you have a small increase, not dramatic, and then over time, this is almost a full year, it goes slowly down. You would never call it a response under normal circumstances. So if you have a chemotherapy patient, you would not even wait that long. You would switch therapy, you would do something else. With immunotherapy, if you live a whole year in a disease where the average lifespan is 6 months, you would still want that benefit. So it's a pattern of influence of the immune system on the disease that should not be discounted. Now then, let's go to the others. This one is particularly relevant, pattern C, where you actually have an increase of the tumor volume first before it then drops. And the interpretation of this graph, which most oncologists would call progressive disease, tumor gets bigger, so we don't like that, so we stop treating, we switch therapy, we call it a drug failure. Well, with the immune system, as I said in the very first statement, we are not treating the tumor. We're treating the immune system. You're recruiting T cells. They go to the tumor. They infiltrate the tumor. There are more cells. Think it's bigger. So that increase in tumor volume is the desired drug effect. It's not progression. But we have to get used to that idea. So a tumor gets bigger on a CAT scan doesn't mean it's a failure. So, and that's what this graph suggests. You see the tumor increase, but mostly through lymphocytic infiltration. And then you should see the decrease to follow, which is then when the tumor cells are attacked by the T cells, the tumor cells get destroyed. So you have to allow for that time delay before you make a judgment about the effect of the therapy. Has never been done in the history of any cancer drug. Whenever the tumor grows, it's a drug failure historically. And I can imagine that many immunotherapies that were investigated earlier on have been declared a failure, even if they could have been successful, because we just didn't know what to look for. So now that's pattern number 3. And here's pattern number 4. It's another interesting observation. In the standard way of assessing response with chemotherapy, any new lesion that appears in a patient is a drug failure. So let's say you have a patient with 5 lesions. Lesion number 6 appears. That's progression of disease. Even if it's a tiny thing, it still is progression of disease. Even if the other 5 go away, it still is progression of disease. That's just the definition from the chemotherapy era. And it made sense at the time simply because under chemotherapy criteria, you never see this. If a new lesion pops up, usually nothing else shrinks. With immunotherapy, you might have a different situation simply because tumor cells that might be spread in the body but are just too few to be visible as a lesion on a CAT scan. When the immune system finds them, you'd crowd T cells around them. That could become visible on a CAT scan. And all of a sudden you have a new lesion that actually isn't a lesion. It's an inflammation. So what we've done here is if you look at the blue curve, that's the tumor volume at start of therapy. It starts dropping. It goes below that threshold of a partial response. But at the second time point, a new lesion appears. That new lesion makes this a drug failure. So in order to get away from that definition, we just measure the new lesion. Instead of just saying there is a new lesion, we measure it, we add it to the total tumor volume of the others, and then the total volume gets judged. And the total volume, as you can see here, that's the green line, it slightly goes up when the new lesion appears, but then in totality it still drops, and you would still want to call this a response. These are simple changes to an existing nomenclature that can make a big difference for drug development between success and failure. So now this looks a little abstract because they're just plots of tumor volume. Let's have a peek at what this looks like in patients. So here's an example, by now a famous example, of a patient treated at the University of Vienna, the place where the Imugene vaccine comes from, but by a different group of physicians, which is a metastatic melanoma on the back of the patient. These lesions are so big, they're almost fist size. And they're hard, indurated, and painful lesions. The patient got treated with 4 doses of immunotherapy over 12 weeks. After the 4th dose, you measure response, the first time we look after treatment start. What we saw was this. These lesions on the back of the patient are larger. They're almost double in volume. But when you look at their quality, they have some detritus. They're soft, they're falling apart, but they're still double the size. So if size is the only criterion, this is a drug failure. If you give this a little bit more time, another 4 weeks later, these big things have shrunk. They're very flat. They're almost gone. But you can still see them. There is skin discoloration that indicates something has been there. And if you then give this more time for the skin to heal, after 72 weeks, this is a complete response. All lesions are gone. There has been no further intervention. There were 4 doses of drug given and no more treatment. So after 12 weeks, the patient was untreated and cleared the disease up to week 72 and has been a complete response over a long period of time. If you now translate that clinical picture into this tumor volume graph, you see a delayed response picture as I've shown you in the previous slide. So this is simple things, but simple things with big impact. So let's look at other pictures. This is a CAT scan now of the leg of a patient, also melanoma. You see big lesions here in the thigh. These lesions get bigger. On the other leg, you see some additional lesions. And then at the 3rd time point, it's almost gone. So this is also a delayed response. It gets bigger before it shrinks. Here's another example, this time stable disease. A lesion in the lung of a patient. So this black space is the lung filled with air. There's a white spot here, that is a tumor. And that tumor basically doesn't change. Second time point. And you can do this 10 times and it will still be the same. But if you live with that lesion for 3, 4, 5 times the time you would normally live, I still call that clinical benefit. So now let's look at a time axis for tumor volume versus time in a very simplified way. So when you look at chemotherapy, you often get, look at the red line, tumor grows, you introduce therapy, tumor shrinks. Recurrence appears, that means the therapy is no longer working. The tumor grows back and at some point kills the patient. With immunotherapy, take that example of stable disease I just showed you, you may never achieve this massive tumor shrinkage, but you may have a time axis that allows the patient to live longer, in some instances by a lot of time. So this is useful even if you don't see a response. So let's look at a few other things that are related to that. Obviously, when you measure response differently, as I've just shown you, you want to be sure that the response is truly connected to a longer lifespan of the patient. So how do we achieve that? We're plotting the survival of the patient. So this is a cohort of more than 200 patients. We're plotting the survival relative to the pattern of response. And we had, when we started this process, we started with chemotherapy criteria and then switched to immunotherapy criteria to catch the new responses. And then we showed both side by side. And that's what is on this graph. So if you take all the patients that have a progression of disease using both criteria, you get this curve at the bottom. That's the worst survival. That's what you usually see with metastatic disease. Then there are patients that have a regular response. That's the top line here. They have the best survival. Those are the conventional responses that you see with chemo, but also with immunotherapy. And then there is this intermediate line, which is much closer to the top line than to the bottom line. Those are the new responses. So you actually find patients that have new responses that also live longer. And that, of course, that's what everybody wants to see. Finding a new response alone is only attractive if it's connected to better survival. So survival is the ultimate readout for most of the studies that we would want to do. So now here's another observation about survival. Now I'm switching gears from response as a measure to survival as a measure. This is only survival data from the phase 3 study that led to the approval of ipilimumab. There are two key features of that study. The first is that the curves between the control group that doesn't contain the intervention and the treatment group which has the intervention don't part until about 5 months. So it takes those first 5 months, the curves overlap. That's the time that the immune system takes to be activated and have an impact on the disease. So in those first 5 months, don't bother to look, because all you're going to see is nothing is happening. If you look early, you may conclude it's not working. And that has happened before. There have been many trials where people looked too early. They're impatient. They want to get a drug to market. They have timelines. They have pressures from investors. And they look. And then you may actually end up drawing the wrong conclusion. That has happened in several trials. You probably know the tremelimumab example, which was the parallel investigation to ipilimumab, another CTLA-4 antibody. A phase 3 trial with tremelimumab was stopped prematurely because they looked too early. The curves hadn't parted. And in any phase 3 investigation, you usually have a data safety monitoring board, an independent group of experts that looks at the data. It's blinded to the sponsor, and they draw conclusions. If they see nothing is happening, they stop the trial. That's what happened in that example. So you certainly want to take that into consideration when designing a randomized study. So now the second piece that we see here is the plateau of the curve. So what you often have in cancer trials is that the majority of patients will still die of disease. Even if they have a benefit, at the end of the day, they still die of disease. What you see here is the curve is dropping, but it plateaus. That plateau is at about 25%. So 25% of patients live a long time. In metastatic melanoma, that's unusual. Usually it's less than 5% of patients treated with chemotherapy that live a long time. So that plateau is an immunotherapy effect. Once you live 2 years, you may actually live 5 years. And that becomes a challenge for drug development with immunotherapy trials in the future, because if you have effective drugs that become standard of care, and it takes a long time for a patient to die, and you need the deaths to show that another drug that comes later has an impact over the existing drug, investigations take a lot longer. So how do we solve that? A proposal we have made is to actually not look at overall survival, where you need a certain number of events to make an analysis of the study. We actually look at rates of survival at 1 year or 2 years, which is a much earlier readout. What you need to, of course, be able to do is say that when you look early, the outcome you see then is the same outcome that you would get when you look late. When you look late, the data is more mature. And of course, regulatory authorities like mature data. So this is an important piece of information. We have considered this design for the Imugene randomized study and a lot of other trials. Now here's one quick picture of how this new knowledge has influenced the ipilimumab program. You see 2 timelines here. The first is the ipilimumab program as it was driven by Bristol Myers Squibb and Medarex, the biotech partner that BMS had at the time. The investigation started in 2000. The first patient was treated in 2000. The approval happened in 2011. It's a long timeline. There were multiple trials. What you see down here is a non-profit group called the Cancer Immunotherapy Consortium that pulled all the information together around improving the development process. And the 2 things have cross-fertilized. So knowing about how to measure response was applied here and led to a drug success. And there were other programs that didn't do that. That did not work out. So having said that, there are a few other things around methods that were happening in parallel with the endpoints. And I referred to that at the beginning. I'm not going through this. But what I certainly can say is it was a very collaborative approach of groups from biotech, pharma, academia, regulatory authorities, and other groups that have worked together to improve the process for drug development for immunotherapies. And we see now that this has led to a very big success in this field. So now, what happened then?
Axel, just as a quick question for investors, I think one of the points that we've kind of almost been conditioned to look for is the median survival. That's been the gold standard for the development of drugs. Could you maybe give us an idea of where you think that's going to move to, and from a regulatory and even from a scientifically accepted point of view within the community, such as the 1 year, 2 year? What's the important data to look for now?
So we're getting into technical information, but so I'll go there. So if you look at the way a clinical trial is usually evaluated, the randomized trial, the overall survival is described with a hazard ratio. A hazard ratio is basically the reduction of risk for a patient to die of disease. And if you look at the HRs here, these are the hazard ratios. Take the first example, 0.68 means a 32% reduction in risk for a patient treated with this intervention. So from 1.0 would be 100% of people die, so there's no impact. The smaller the number gets, the greater is the impact. So a 0.68 means 32% less than what you normally see. So the hazard ratio summarizes the totality of the effect over the entire length of the curve. But it's for most people too complicated to deal with a hazard ratio. So what do? You sum it up in one number. And that's usually the median survival. It's a single number. That is when 50% of patients have died. So the median would be here. The median is somewhere around, for the lower curve, around 8 months. For the higher curve, let's see, with the 50% is here, the higher curve is here, it's about 10 months. So the median tells you a tiny piece of that much larger story. What we're really interested in is this tail of the curve. There are 25% of patients living longer. If you look at the median is here. We haven't even gotten to that plateau yet. So the median number is a simplification of the result of the trial because it's so easy to deal with an individual number. You say, okay, this median survival has been improved from 6 months to 8 months, or from 8 months to 10 months. Only tells you a fraction of this story. So I think in the future, for immunotherapies in particular, we need to step away from the summary of a median survival. We can continue to use the hazard ratios. They are comprehensive. But we want to then look at survival rates, for example, or that plateau. and the survival rates are down here, when you can say 44% of patients are alive after a year, that's also a meaningful statement, and it's much more useful than a median survival. So I think your point is we're switching from medians to survival rates.
So the other thing I think, I imagine the investors in this room looking at that, and they're going to say, you're saying, is the FDA going to require all that data?
Yes, they do.
When do we begin to feed the FDA data? Is it at the time points, or do you think they're going to insist right to the end of the trial?
So a trial like this,
25% still alive.
a trial like this, if it's a pivotal study that is intending to achieve a regulatory approval, it's blinded, and you only look at the data at the very end of the trial. So if it's designed to achieve a certain number of events, let's say there are 500 patients in the study, you prospectively define 400 of those patients must have died before you do the analysis, and it takes a long time for that to occur, then you will wait until the study is ready. If you look at survival rates, you will look much earlier, because all you need is follow-up of all patients for 1 year. And after 1 year, you look. But it's only a part of the story, right? What happens later, you don't know yet. So if there is a correlation between the early look and the final data, and you can show that a few times in multiple trials, you would start to build a body of data that regulatory authorities might find attractive, and then believe the concept of a survival rate being a meaningful endpoint. We're in the process of having that dialogue with regulatory authorities, but there is no adoption of a new endpoint yet. It needs a body of data. And there's enough data being generated by this community now, because there's so many big programs. So I expect this will come, but we have to give it a little bit more time.
So Axel, just with that, it kind of potentially implies that immuno-oncology endpoints should be different.
Yes.
But do we not then get into a grey area of what you define as an immuno-oncology therapy versus a traditional
So
therapy?
I don't even say that this is absolutely unique for immunotherapy. We just know that the biology here supports that we use this for immunotherapy. It makes good sense. It describes the effects that we're looking for. For other therapies, you could try this too. Some of the targeted therapies, some of the stem cell therapies that are being developed have different kinetics than chemotherapy as well. And you might want to capture those. So these methods are not immunotherapy methods per se, but they just fit very nicely to immunotherapy. And they could also fit elsewhere. So I guess I'll just keep moving. Look at now the endpoint of this entire tipping point story that I'm trying to tell you, is that in the past we called immunotherapy, drug development for cancer, oncology. It's a well-established area of science. We have certain ways of doing things in oncology. Now we've learned something new, and we actually start to introduce new science that most oncologists are not familiar with. Immunology. Most people have not been trained in immunology to the degree that you need to fully follow all the details here. So we basically established a subspecialty of immuno-oncology, and it's moving quite fast. There's a lot of new expertise coming into oncology. New investigators get trained, young investigators get trained on a new science, and we see trials that have never been done before. So it's an exciting development. There are lots of new drugs emerging now, using mechanisms that we previously did not investigate. So, and immuno-oncology has become a buzzword, obviously. I think you all have heard it. Now, let's switch from the tipping point piece to the state of the field. So it's basically the extension of what has happened since we got the first approval. There's so much new activity in this area. We have started to more comprehensively look at what are all the mechanisms that the immune system can offer. Checkpoint modulation is looking very attractive. There are many targets in that area, but it's actually a small piece of a much larger story. And so let's look at what that story is. This is my way of describing what the field of immuno-oncology looks like. So the way to read this graph is it starts with the black boxes on top. They basically describe three basic mechanisms of the immune system. The first is T-cell immunity. Basically, you're activating T-cells against a certain target. It takes a little while for them to grow to large numbers, go to the cancer, and start fighting tumor cells. It's adaptive immunity. That means you're teaching those T-cells what to do. Then you have the B-cell immunity. Falls under the same category of adaptive immunity. So you're teaching B cells, in this case antibody factories, to make antibodies against the tumor cells. So those two are very frequently used mechanisms against disease. Whenever you contract some kind of disease, those mechanisms become activated. Now, the third piece is innate immunity. Innate basically means it's not specific, it's not focused on one specific target, but it moves much faster. You know, adaptive immunity, you need to see the target, the T cells need to recognize it, they need to divide, and you build that army of cells. It takes weeks. Innate immunity, these cells are already there. They're not specific for the target. Whenever there is a disease, the NK cells or macrophages will go straight to the problem. So it moves faster, but it's less specific. So you could activate any of those three categories to make an immunotherapy drug to fight a disease. In our case, we're fighting cancer. Now, everything underneath those three categories are different modalities that we have started to use to make drugs, to manipulate the immune system. And some of this stuff you know. So for example, cytokines are around for a while. They haven't yet delivered what we were hoping that they would, but they're drugs, they exist. The cell therapies and the T-cell checkpoint modulators are highlighted here in red. Those two categories have led to approved drugs that in randomized trials have shown survival improvement for patients. So those are validated modalities. The first cell therapy that was approved is the Dendreon vaccine. It improves survival. It has not been a commercial success, but it does improve survival. The T-cell checkpoint modulators are big commercial successes. They're antibodies, they're easier to make. Ipilimumab was the first. Pembrolizumab, the Merck PD-1 antibody, has just been approved this year, was the second. And there's a long list of others that are pushing into the space. Then there are cancer vaccines, a variety of mechanisms, how you can activate an immune response against a certain target. They have not yet been successful. There's a lot of investigation going on, and it's around T cells. There are bispecific antibodies down here. There are oncolytic viruses, and then there are adjuvants. So different mechanisms. I'm not going to go through the specifics right now. They're all being investigated. Different technologies. In the most part, they're using T-cell mechanisms. Now, that's half of the story, this half. The other half is B-cell immunity and innate immunity. A lot less has been done there, but there is activity there as well. Technologies are being built, companies are being formed, and there's clinical trial activity. I'll come back to this in a little bit. So now, if we zoom into the immune checkpoint modulator box, just that one box, where ipilimumab is in and PD-1 is in, those are the targets that are currently characterized in that category. And there are more targets coming to the table every day. So here you see CTLA-4, you see PD-1, you see ICOS, and you have a variety of others. There are antibodies made against those targets, but which are being investigated. Some of them are in clinical trials. So that's the checkpoint modulator area is growing. There's a lot of stuff going on. I think this is a validated area. It's just at the moment, not all targets have been tested. Now, if you look at the way the data in this area, checkpoint modulation is emerging, it came in two waves. Wave one was ipilimumab and tremelimumab, two CTLA-4 antibodies investigated in melanoma. The first approval was in 2011. That's when the story took off. And from that point on, you see this wide expansion of more programs in this area. I'm naming 4. There are more. Those 4 are mature. They're in pivotal trials. So those are PD-1 or PD-L1 antibodies either from Genentech, Merck, Bristol Myers, or AstraZeneca. We will see data from this. As you've heard, pembrolizumab from Merck has already been approved. The others are at its heels. Now let's look at some data. I don't want to go through the whole table, but I think the flavor that you get from this is that in the past, we have always said there are some immunogenic tumors. Melanoma is number 1. If an immunotherapy works, it will likely work in melanoma, but probably not elsewhere. I think we've disputed that by now. There's data from 4 major programs across a variety of diseases that says it can work in other tumors, like non-small cell lung cancer. There's the melanoma line, kidney cancer, gastric cancer, head and neck cancer, and then bladder cancer. That's the first wave. There are other diseases being investigated, and I guarantee you will see other diseases that would have never been thought of as immunotherapy amenable diseases. will have activity with these drugs. So I think we're going in the right direction. The immune system can be used against basically any cancer. Now here's another slide about deal activities in the space. This is actually from 2013. It's a year old. And you can see several big companies have done deals with smaller companies, or small companies have been founded. And a lot of valuation is placed on cancer immunotherapy. And you know this better than me. This is your area of expertise, so I'm not going to dwell on it. So what I would say with all of this is, we have looked at was already very exciting, goes in the right direction, but it is the tip of the iceberg. There's a lot more under the surface that we still want to leverage. And the question then is, what is that? So I'll come to this as the next frontier. And now the next frontier, in simple terms, falls in three categories. The first one is, what are the new mechanisms? We have spent a lot of time on T-cell immunity and various modalities you can use to address T-cells or target T-cells for them to fight cancer. There's other stuff, and we'll come to that in a minute. Then there are combination therapies. A big trend in this business is to combine drugs with each other to achieve transformational effects. And transformational means these big improvements over standards of care. I'll illustrate that to you in a minute. And the third piece is biomarkers. We actually need to be able to select patients better, figure out which drug works in which patient, what side effects a patient might expect from an intervention, and how do you combine drugs intelligently based on pharmacodynamic data, or in other words, biomarker data. So these three areas, if we address them, this field will explode even further. So here is the vision of how we think immunotherapy needs to evolve. So I've shown you the survival curves earlier. Those two curves here, the purple one and the blue one, they basically are more standard curves. Classic oncology drug development curves. There's a drop in survival of patients, and it almost goes all the way to the bottom. The majority of patients die. And when you improve this, you shift the median. Still, most people die, but they live a little bit longer. So that goes to the point we had earlier. The median survival was somewhat a reflection of the overall drug effect with that phenomenon. Now we introduce immunotherapy, and you see that plateau. You no longer capture that plateau when you look at the median. So you now need to look at long-term effects. And for the ipilimumab data set, that plateau was at 25%. Our aim now has to be to get that thing higher. So instead of 25% of patients living a long time, you want 50, 60, 70% of patients to live a long time. That's what this suggests. And this is a very achievable objective through a variety of means. So let's have a peek at what those are. Mechanistically, as I've shown you, cell therapies and T-cell modulators have been successful in this space, and success is measured by regulatory approval and then subsequent commercial success. Now, if we switch from there to the other side of the spectrum, there's lots of stuff already happening in the T-cell space. Other things that are interesting is B-cell immunity and innate immunity. You see new technologies emerge in this area, and one of those is Imugene. So Imugene is the next generation of innovation in immuno-oncology beyond the T-cell space, and it falls here under cancer vaccines. It's a B-cell vaccine, not a T-cell vaccine. Historically, almost everything you have seen in the past under vaccines has been T-cell vaccines. So now I show you only one slide on Imugene, because the focus here really is on immuno-oncology. It shows the mechanism of action. So what does happen with this B-cell vaccine? You create a peptide that is able to stimulate a B-cell to make an antibody against a specific target. You inject that peptide into the patient, the B-cell produces the antibody goes to the tumor cell that carries the target, and then once they bind, they destroy the tumor cell. So that's the basic idea. So you turn the antibody factory, which a B-cell is, into a tool against the tumor. So that's the mechanism of action. I'm not going any further on this. All right, so then let's talk about combination therapies, the next thing that can really boost the benefit for patients. So here's an example. You might like this. This is the London subway map. Why do I show you this? because it's a complicated image of many different pathways within a certain space. So in the city of London, you have many subways. And if you want to impact on one pathway, you block it. Assume these are pathways in cancer cells. You block that pathway. In this case, you have 2 blocks in one subway line. If you go to the MAPK pathway, you have a BRAF and a MEK inhibitor. It's the same idea. You get an impact on the disease. But if you want to subvert the problem, you just change subway lines, and the problem continues to persist. So it's a short-term effect that you achieve with that blockade. You can do something else. You can just block 2 subway lines. But there's still enough other pathways. So there's always a way around it in a complex network like this. So how do you get around that problem altogether? You look at a mechanism outside of that system. And that's the host immune system. It's always there. You can teach the immune system how to kill the tumor and not having to look at the subway system at all. And there, with combinations, you could actually have an impact on the tumor short-term with a targeted therapy. Works very well. And then you add an immunotherapy to it to achieve the long-term effect. That means you want that plateau for the patient. And together, they may be much more effective than either one alone. So now, let's look at what that looks like in that time axis that I've shown you earlier. There's a new curve on here now, which is that green line, standing for the combination. So you have that response. Tumor grows, you give the therapy, it drops. Once it has dropped, you achieve a response, and then you want to keep that response. So it persists in this example, and the patient will live much longer than with the individual therapy. Obviously, that's a hypothetical here. That's not data. But there is data that suggests that this can be achieved. So the first data set is a mouse experiment where we combine a targeted therapy with a checkpoint modulator. In this case, actually, interestingly, already the next generation checkpoint modulator against an NK cell target, which is innate immunity. So that thing is called CD137 and is combined with trastuzumab, which is Herceptin. Very well established targeted therapy. In these experiments, just to make it simple, mice either get trastuzumab alone or CD137 alone or the combination. And what works the best here is the combination. The tumor growth curve remains flat, while in the other examples, the tumor grows fast. The curve goes up. And it basically means at some point these mice succumb to disease. So the mechanism here is interesting. It turns out that HER2 inhibition upregulates CD137 on NK cells. This is an interesting observation because historically, when you give a targeted therapy, you always look at the tumor. You don't care what happens with the immune system. So somebody actually bothered to look at the immune system and find out that there is an effect of the targeted therapy on the immune system, not only on the tumor. And now that you know that, you leverage that information and give an immunotherapy on top of it and get a better effect. So characterizing a targeted therapy's effect on the immune system, not just on the tumor, what it was designed for, has an impact for the overall use of the therapy, particularly for combinations. And you know we have this spectrum of targeted therapies. They have never been checked for what they can do to the immune system. If we do that, you open a whole other universe of opportunities to achieve big effects. So now, here's a data set from ASCO from 2013. This is the combination, this is now human data, of PD-1, nivolumab, and CTLA-4 ipilimumab in a phase 1 trial. Here, this is metastatic melanoma. It's phase 1 data, so it's early, but it has a lot of follow-up. The plateau of that curve is fairly high. Remember where we were with ipilimumab alone, that was at 25%. That plateau is already much higher. And it's a phase 1 study. This needs to be confirmed. You need more data and so on. But it is a clear indicator that combining drugs can probably lead you to bigger effects. And lifting that plateau of the curve is the desired effect. Now let's look at biomarkers. Last piece. This is a snapshot of a tumor. When you zoom into the tumor, it's full of cells. What we have done in the past was always look at what are the tumor cells, what happens to those tumor cells. Maybe we were looking at stromal cells, the connective tissue that holds it all together. But we rarely looked at the immune cells in that tumor. Now we've gotten really interested in those immune cells because that's what we're targeting with immunotherapy. It's no longer the tumor. So and here's just an example that shows you the complexity. There's a large number of cells in a tumor that are not tumor cells, that are usually lymphocytes of different flavors. And for us to recognize what are they, understand the ratio of those cells towards each other, how many suppressor cells do we have, how many effector cells do we have, how do they play together, is an essential piece to understand, and then use the therapy accordingly, according to the situation in the tumor that the patient already has at the time when you start treatment. So biomarker development runs in parallel with drug development and can help that picture substantially. So now go to an example. Actually, I'm not going into depth here, but there's one thing to be said. There's a lot of data already coming primarily from colorectal cancer where people investigated the effect of lymphocytes in the tumor on the overall outcome of patients. And the effect is substantial. The effect is stronger than the entire staging system that we have crafted over so many years to stage a tumor and say a patient with a small tumor lives longer than a patient with a big tumor, for example. Now you would say a patient that has lymphocytes in the tumor lives longer than a patient that doesn't. That's a simplification, but that's where it's going. Understanding the biology makes a difference. Now here's another interesting observation. This is a mouse model, very simplified, showing an either immunocompetent mouse, so a mouse that has an immune system, versus a mouse that doesn't have an immune system. You treat these mice with the same kind of chemotherapy intervention. You get a therapeutic effect in the immunocompetent mouse, but not in the mouse without an immune system. Why is that? Because the chemotherapy doesn't only work on the tumor. It has an effect on the immune system. And what you probably measure in patients when you look at survival is the cumulative effect, the toxic effect on the tumor, and the eventually supportive effect on the immune system, if it exists. So you want to know that. And there are biomarkers you can use to figure this out. So here's another example of the survival of mice and the tumor growth of mice with two different chemotherapies that are usually very similar, two platinum-based chemotherapies, cisplatin, CDDP, and oxaliplatin, OXP. This is oxaliplatin down here. This is cisplatin. And the third line is the control. So this is an immunocompetent mouse. It has an immune system. Oxaliplatin does a lot better than cisplatin. If you now go and knock out the immune effect through a third intervention, the oxaliplatin effect goes away. If you do the same experiment in the nude mouse that has no immune system, it's the same thing. So oxaliplatin differentiates itself from cisplatin only in the model where you have an immune system, suggesting oxaliplatin has an effect on the immune system. It's not just on the tumor. So knowing that information and being able to create biomarkers that help you describe it enables you to pick the chemotherapy that might be a good combination partner for an immunotherapy. So that's what I'm saying with biomarkers. You can pick out information that is very valuable for drug development. So and then my last example, now I'm coming full circle back to the methodological statement I made at the beginning. The reason why immunotherapy is successful is twofold. We have made progress in science, but we made progress in methods. And this is an example of a biomarker method that makes a big impact on measuring immune response. So what is this thing? It is the measurement of an immune response in the blood of a patient, a single patient. You draw the blood from the patient, you split it in 36 different buckets and give it to 36 different laboratories to measure immune response against the same target with the same assay. And that's what you get. Every well here, every circle has a certain number of spots. Every spot is a T cell reacting against the cancer cell. This is laboratory 1, laboratory 2, 3, 4, 5, and so on. The variability of this data coming from one blood sample from one patient is amazing. So if you try to use that data to correlate it with clinical outcome, there's nothing you can do with it. So we need to improve the method that's being used here to achieve that data. So we can say, yes, we know what immune response we need to look for, but we also need to use the right method and a harmonized method used the same way by everybody who does it, so the results are reliable. If we don't do that, don't even bother. It costs money, but it leads to no result. So and here is what happens when you harmonize the use of the assay. The picture I just showed you is this point, 47% variability of data across the 36 participants in that experiment. If you repeat the experiment and you reduce the variability by harmonizing the way the experiment is done, so the 36 labs are doing it more similar than before, it goes down to 14%. If you then take another step, it can go down to less than 10%, and that starts getting acceptable in terms of data reproducibility. So the progress we have to make, and the progress we're making, is in the side of the science. We have to understand which biomarkers to look for, but also on the side of methods, how do we measure this? Because if we don't do it right, the data doesn't help you. So I think altogether, this field has tipped over, and it's going in the right direction, and the explosion that we see is a very justified explosion because the results we get are more reproducible, and the benefit we get for patients are bigger. So I think immunotherapy is here to stay, and you will see immunotherapy will likely offer, at least for some patients, the potential for cure, which is a word that we have not used in oncology very commonly in the past. So that's the story I'm telling you. There's of course a lot of detail here that I haven't spoken about. If you have questions, ask them. And this is my final message as I just click through them. The bottom line is we're always looking for innovation in drug development, right? The next thing, the next better thing. Immuno-oncology is such a rich area, and we have really just started. You will find a lot of innovation there and a lot of value that can come from that innovation. You can generate more benefit for patients. You have more broad mechanisms you can combine with each other to get transformational effects. You need to develop the biomarker story, which is what happens. And then, of course, you need to apply a development paradigm that does justice to the biology of these interventions. So if you don't do that, treat it like chemotherapy, you will get chemotherapy results. And that's not really what we want anymore. So having said that, I think I'll stop at this point and make one final statement, another important statement from my personal perspective, and advertise for a meeting, a cancer immunotherapy meeting, that is going to take place in September next year in New York City. That is going to be the largest meeting in this space, and it is particularly interesting for one reason. If you look down here, there are 4 sponsors for this meeting. AACR, the American Association for Cancer Research, EATI, the European Academy of Tumor Immunology, CIMT, the Association for Cancer Immunotherapy, and the Cancer Research Institute in New York City. Those 4 team up to make the biggest meeting in the space, instead of doing 4 meetings, each for one of those organizations. 4 small meetings versus a master meeting for the field. So that also means you can unify different groups that usually do their stuff on their own and achieve a bigger effect just here for the community. So I think this is worth going to because it will be great networking opportunity, it will be deep science, and it may even be an opportunity to pick out some deals for new technologies.